You can start with the slides. The first one. Okay. Okay. So I welcome everyone who has joined us. I want to introduce you first to MediQuest. So MediQuest is something that we had been thinking, me and Saurabh, since long. So this is something sort of platform that we have thought of. So in this platform, we will discuss about the most relevant issues in the critical care medicine with the stalwarts and the faculties of the in the field. And this will be an interactive way of learning. And this way we can understand the finer details about the situations where we all people who are working in intensive care unit, we deal with our daily practices. So that should help us in getting relevant information, updated information over the relevant topics, and it should also help us with our daily practices. So there is a web page of MediQuest on Facebook that you can join, and all the participants about the individual meetings can send us questions and the scenarios where they find it difficult to manage, and that we can put with our experts, and that should help you. So we will take up all your questions, we will compile them, then we will invite our guests, and then we will interact with them. And with that interaction, I think we will be able to answer all your questions. And even after that, we should be able to help you with whatever you want to know about it. So this will also help you as your doctor in your knowledge, and this may also help you in getting your outcomes of the patients improved. Right, so that is basics about the platform of MediQuest. Saurabh?
Okay, thank you, Dr. Sandeep, and thank you for giving me this opportunity to be part of this program. First, let me I think everybody, this slide is not moving.
Slide is with you only.
It is not moving. Just a minute, let me move. Sometime it takes time. Give me 1 minute. Okay. So I think let me introduce Dr. Sandeep. I think he is already a familiar name. Many of you, I think, must have read his book, that is MCQ in Critical Care Medicine. It's very popular book. Now he is heading critical care medicine in Terna specialty, that is in Navi Mumbai, and he has wrote 2 books. One is MCQ in Critical Care, and another is Cases in Critical Care. Both are very useful for exam goers. He is also the teacher, have been teacher for ITCM for a long time, and his faculty at numerous conferences. He has also co-founded and director of Ease Life Healthcare. It is more, I think, more is home at ICU concept it has. So this is new. The second edition is coming very soon. I think we are all waiting for this book. It will, I think, come in few months. Okay, and it's about me.
And
okay.
So this is Saurabh. Me and Saurabh, we know each other since years and years. And of last few years, Saurabh has really come up with what we have always thought of doing. So he is right now working as a senior consultant in Max Specialty Hospital, New Delhi. He has a lot of publications. 24 is something that he says, but maybe more than that. So he's a teacher and examiner for DNB and IDCCM. He has recently founded a Onco-Critical Care Society, and he is secretary of that, and he is starting this Onco-Critical Care Journal also, and will be seeing the first edition very soon. He's also written a book on essentials of critical care for practical examinations. That I think it was OSCE's based book that he had read. Right. So welcome, Saurabh. And next slide, please. So for today's topic, the topic is advances in ARDS management.
Yes, this
Can you
is,
move?
yeah, I have tried sometime.
Okay. Okay.
It's
Anyways, so for this topic, we had requested Dr. Sumitre sir to join us, and he has graced us with his presence. So you can see it in the slide, but he's, I would say he's my teacher and he's my mentor. I worked and learned from him in Gangaram Hospital during my FNBs. So sir has, I know that because he has taught us, he has very, very keen interest in ventilators and ARDS, and that is why who better than him to guide us with the advances in ARDS. So right now, sir is working as head of the department and medical director in Holy Family Hospitals. He has 15 international and 26 Indian publications and 16 chapters. You must have read so many articles in newspapers, websites, and chapters on books. And he is secretary of Indian College of Critical Care Medicine. So this is very, very small introduction about him. And since I have personally worked with him, so I know he's much, much, much more than that. So welcome, sir, and thank you for giving us your time.
Thank you so much for the kind introduction. I hope you can hear me. Is the
yes,
audio?
Yes, sir.
loud and clear.
Right. Thank you. Thank you, Sandeep and Saurabh are some of the brightest people I've worked with. I've had the opportunity to work with Sandeep, as he said, in Gangaram Hospital, and I've had the opportunity to work with Saurabh at Artemis Hospital, Gurgaon, and I know both of them are very academically oriented and research oriented. So, and I'm sure this will be an interesting session, and they will put up the questions in the discussion. I think, my role is supposedly to, give certain answers, or my experience, as they say, as we grow older, it's, we start talking about experience, but also probably evidence. We'll look at the evidence, but also I would like Sandeep and Saurabh to participate as much and add, or to what I have to say, not just add, maybe put in new things, new ideas, new evidence. They are very up to date with everything. So I would like you to join in as much in the discussion as possible and not just moderate it. Thank you.
Thank you, sir. So to start, this is the newest, the latest one, the ESICM guidelines on acute respiratory distress syndrome. So this guideline talks about definitions, phenotyping, and updates on respiratory support strategies. So I'll start with a few data regarding the definition, and then we will put up some more, ask sir about some more new information about it.
Sorry for this glitch. Can you see now?
Yes, yes. I think don't make it a full screen. We can go through this. So to start with, as we all know that ARDS has been long recognized disease, but the first definition was given by American European Consensus Conference. So then it was updated in Berlin conference, called Berlin definition in 2012. If you see, there are few differences. If you see about the onset, so it says about acute onset, doesn't specify. Berlin definition says less than 7 days since the onset of the inciting condition. Then there should be bilateral opacities, which is kept here, which is not attributed to pleural effusion or nodules, non-cardiogenic pulmonary edema, and they have defined how to check for non-cardiogenic pulmonary edema. Oxygenation, they have in Berlin definition, they had defined by use of PO2 by FiO2. One of the critics of AICC definition was not non-inclusion of P, which was included in the Berlin definition. So they had divided it into three: mild, moderate, and severe ARDS. Acute lung injury term was taken out. Now, in AICC, there was no specific predisposing condition which was performed, but in Berlin definition, they had said that you should have some predisposing factor. Now, with this newest guideline, they have again questioned few things, which is relevant to the definition of ARDS. Now, they say that in Berlin definition that the PEEP should be more than 5 centimeters of water. So there was questions which were raised in this guideline, which you can read in detail, that HFNO was proposed as a big therapy, very, very useful therapy, but you cannot use it consistently with PEEP more than 5 centimeters of water. So how do you define it if we come to the definition of ARDS when the PEEP, when you are using HFNO or some other form of oxygen therapy where you cannot keep your PEEP of more than 5? They've also said that during the defining periods, Berlin definition says that it should be less than 7 days, but that also has been questioned, because there can be a latency period of more than 7 days, maybe up to 14 days, especially in viral pneumonias. Third question which was raised in this guideline was, should you use SpO2 by FiO2 ratio instead of PaO2 by FiO2 ratio, because SpO2 is continuously available to you and you do not need invasive blood gas monitoring, which may not be available at multiple places. And lastly, they have also raised a question whether the radiographic criteria should always be bilateral infiltrates, or can it be 2 quadrants, and which can be unilateral also. Can ARDS be unilateral, which is against the teaching that we have already received? So I would request sir to put some light on this.
So which one, the last one, or you want all those points, or?
Yeah, some comments on all the points, sir.
Right. So I would think that, the use of HF, starting off, rather than answering one point at a time, in general, I think in principle, 2-3 things. One is, as it's a syndromic definition, we have to probably be very clear when we are defining. One is defining it for purposes of doing a research study where you have to fit in all these things together so that your research methodology is not questioned. In the clinical setting, I think what we need to rule in is an acute onset, which could be anywhere within 7 days, sometimes 14 days, depending on the timeline. And it's like not a waxing and waning phase, but a continuous phase of the illness, and acute illness, which could be anywhere between 7 to 14 days. I agree on it. And how do we define ARDS would be by negating the fact that there is a hypoxemia which is not related to a cardiogenic failure, not related to an embolism, not related to a underlying interstitial lung disease, etc., or a pneumothorax. If it's an acute event, all these elements have to be taken out. Once we have taken out these elements, and then what is left with a significant hypoxemia, I think in the clinical setting, we manage it in a sense like an ARDS, while we do the rest of the investigations, or watch the patient and see how it goes, and will this patient continue to fit into the criteria of ARDS in the next 12-24 hours. For clinical management, I think ruling out these elements and ruling in an acute onset broadly with a significant hypoxia with a PF ratio less than 300, broadly, even if as the HFNO, if we start using HFNO, if the high flows are required and the PF ratio is less than 300 and high flows are being required, even if the PEEP generated, we are not sure, I think we should start treating it as an ARDS and then take it from there. Yes. In the clinical setting, I think I would agree with most of the things, except I would still think that ARDS, when we define it as I think it should remain a bilateral one. The reason being, we are looking at a systemic inflammatory response or a systemic insult hitting the lungs, which is causing, which can be, the trigger could be anything. Its trigger could be a pneumonia, or a trigger could be a pancreatitis, or a trigger could be a trauma, but hitting the lungs. And then if we expect it is a systemic inflammation which is causing the damage, it needs to be bilateral. I think the unilateral, then we have to make the unilateral definition. I think that should not fit in here, because then we have no way of looking at what is a pneumonia leading to a hypoxia and an ARDS leading to an hypoxia. The management in some ways will be similar, but in some ways will be different.
Correct. Okay. Correct.
Correct. Right, sir.
Anything you would like to add, Saurabh? Or
No, only thing that, sir, now as they have started, like, see the subphenotype of ARDS.
Yes.
Now they have divided ARDS with radial fissure, primarily unilateral or bilateral, and they have found unilateral, they have better prognosis than the bilateral. They showed. So in this,
sorry, come again. Unilateral has
better prognosis.
yeah.
Than bilateral. In this guidelines only they have mentioned like that. So by this definition, definitely it is difficult to say that unilateral. It is difficult to diagnose ARDS when it is unilateral.
Yes.
Bilateral, and in original definition they mentioned about bilateral.
Right.
And by the pathophysiology also, it should be bilateral. I mean,
Yes.
this is a systemic inflammatory response which has to involve both the lungs. But yes, in these guidelines, they have talked about and focused about the unilateral also,
Yes.
which is strange. I mean,
So, okay. So, next question, I want to start with a very basic questions. Dr. Sandeep, as sir said, I had the opportunity to work with him for nearly 3 years, I think. Yeah. And every day I used to ask him questions, not only related to critical care, everything from France Revolution to Assam Accord, everything. And not a single day he was irritated or annoyed to me. And thank you, sir, again, for giving me opportunity to ask the question again. So this question is very basic. It is like, which mode we should initially start to ventilate in patient with ARDS? We know the advantage and disadvantage of volume control and pressure control mode. Volume control, they assured volume, and pressure control, they may be little benefit as in hypoxia, because they have high mean airway pressure than volume control. But when we don't use a long inspiratory time, when we use P, or when we use volume control with deaccelerating flow, I think this advantage is not there. In initial studies, when they compared with these two modes, they showed better result with pressure control mode. But in 2015, there was a meta-analysis. It was done, this Cochrane meta-analysis, and it was done by CMC Vellore researcher, Binula Cheko et al. And they found, they studied around 1,000 patients, and they found there is no benefit over one mode over another. In this scenario, when there is evidence lacking, as a student of critical care, how should I start? Which mode should I start to ventilate in patient with ARDS initially?
Right. So I would say, based on experience, based on the evidence to a certain extent, and there is no perfect evidence for this, I would initiate on a volume control when I'm initiating. And that doesn't mean that I'm going to continue doing it for the first 24 hours. When I'm initiation, only the first few minutes and hours, while I stand and watch what is happening to the patient when we initiate ventilation. The reason being, probably you get a better idea of the respiratory mechanics with volume control mode, the pressure time scaler,
right,
the volume scaler. You get a better sense by fixing a tidal volume within a certain inspiratory time with a certain pause time when you have a plateau pressure. And you differentiate between the plateau and the peak pressure, which gives us an element of how much is the dynamic compliance and how much is the static compliance elastance, which with pressure control is difficult to monitor.
Right.
Once you know that, once you have a sense that, okay, this element is the elastic, the static compliance is this much, the dynamic compliance is this much, the resistive element is this much, then you can manipulate. If the resistive element is pretty low, which you would expect in most ARDSs, but you have a combination of disease processes, then you may not get it.
Yeah.
Then you can decide on moving to a pressure control, knowing that the pressure control and the plateau pressure would be similar if the difference between the peak and plateau is not too much, right? What you set for pressure control, the upper limit you set for pressure control. But I initiate on a volume control, watch it and see. And in the first 24, and then if you want a deaccelerating pattern of flow, for two reasons you go to a pressure control. One is synchrony, which you don't really need in the initial phase as much because you are deeply sedating. You're not trying to start the process of weaning, etc. And sometimes using a muscle relaxant, and we'll, I think, come to that a little later. So at that time point, I think using the volume control gives you more information about the lung mechanics and the respiratory mechanics, not just the lung mechanics, and also gives us an idea about the, the pressures, the effect of the intra-abdominal pressure, etc. And we'll come to that later again, I think.
Yes.
So I would initiate there, go to pressure control if I feel that I need to increase the mean airway pressures by increasing the inspiratory time, changing the IE ratio to an inverse ratio if it is necessary. Sometimes it may not be necessary.
Yeah.
Right? So depending on those factors, I may or may not move to pressure control in the first 24 hours, but I personally tend to use the volume control mode because I think I get more information about that particular patient with the volume control. And it is usually easier to titrate PEEP, if to titrate PEEP with a volume control mode, particularly if you are new to the game, right? With a volume control mode, then with a pressure control mode. Having said that, it is possible in all modes. Okay, with the modes.
Dr. Sandeep, do you want to add anything?
You would like to add to it?
So is there, another question is, which is a common question is there anything related to mode? We will come to rest of the ventilatory parameters later.
Right.
But is there any mode, say at some point of time, APRV was considered to be the mode to be used in ARDS? Although it was a little complicated than all these modes,
Right.
but it didn't turn into life-saving mode or a mode which gives you a better outcome. So is there any specific mode, which is the commonest question? Modes are very, very common questions. Is there something that can really help these patients?
So as you answered the question, I think there is no mode which has benefited. One study, APRV being better in outcomes for ARDS mortality, 138 patients on each arm, multi-center trial from China, showed a benefit for APRV, but this is the only trial which has showed a clear benefit. So I would go just by one trial. Having said that, I find APRV a very fascinating, interesting, and a difficult mode to use. I use it, but it's not an easy mode to transmit to a person who is new to mechanical ventilation, because it reverses the whole principle of how we ventilate, right? We always ventilate from a lower pressure to higher pressure in every mode, right? When we inflate the lungs.
Correct.
APRV, we ventilate from a higher pressure most of the time to a drop in pressure.
Correct.
And the higher pressure is for a long period of time, and the patient can breathe spontaneously on these two levels of CPAP. Right. And this prolonged, it's an inverse ratio ventilation by its very nature. So its mean airway pressures are increased and oxygenation should improve to that. But what is probably difficult to understand is that your ventilation and your de-recruitment is controlled by your release time and your release pressure. How well you can tweak that so that the most important graphic in volume control mode in pressure, the most important graphic in an ARDS patient is a pressure time scalar, pressure volume scalar loop, right? But in APRV mode, the most important scalar is the flow time scalar, where you look at the expiratory flow. So it's you change many concepts of how we look at the ventilator, how we ventilate the patient. So it's a difficult one. Do I use it? Yes, I do use it. Not all the time. I also am aware that sometimes when I put it on the patient and at night, when they are not very sure, the gases are changing, when they change back to a pressure control or a volume control mode. These are possibilities. Is there a chance of more barotrauma with that? Yes and no, depending on the level of sedation, comfort, and synchrony. Because if the patient bucks and coughs on a high level of CPAP that we are giving, because the patient is allowed to breathe spontaneously for a long period of high CPAP, chances of pneumothorax are there. Second is the phase when they are most susceptible to pneumothorax is actually when they are recovering. When the compliance is improving, then you have to titrate, dial down the pressures that you are using in the upper pressure limit, right? All these have to happen as a team, because you may be the person who knows APRV and the rest of your team is not very sure and they don't time things. And we have had, pneumothoraxes because of the lung becomes better rapidly sometimes. I mean, just had like a few months back, H1N1, girl with H1N1, improved dramatically, the oxygenation and everything, and the lungs opened up within 24 hours. And at that time, and it was improving, we needed to dial down the pressures and the P high and the T high. And probably in some ways we delayed that, and the patient had a pneumothorax. Young girl, ARDS with a pneumothorax, it's bad scene. A chest tube in a bad ARDS is a bad thing. She was young, etc. She was lucky, she survived. But that is the worry with that how do we dial down the APRV support as the lungs improve rapidly, if they do improve rapidly. So that's the worry with APRV. I know it's a long-winded answer to a short question, Sandeep, but yeah, I thought talk about APRV a little bit.
That is the crux of it. So the message here is probably all the modes are equally good. It is how you can use that mode, how familiar you are with that mode, and how comfortable you are, how best you can use that mode. That is something which is going to matter rather than the fancy names of the mode.
Even actually only to improve hypoxia, only two things they work. One is mean airway pressure and one is FiO2. APRB is nothing but to keep mean airway pressure high and to release it for a shorter time. Right, sir?
Sorry, it's slightly louder.
And what I said, like only two things matter to deal with hypoxia. One is FiO2 and one is mean airway pressure. There is no mode like APRB is maybe useful to prevent hypoxia because it maintain a high mean airway pressure for a prolonged time, and they release the airway pressure for a shorter time. It is the like high PEEP or high mean airway pressure is almost like same. I don't find very different this mode from other or when we use high PEEP.
If you can see my hand,
yeah.
Most of us, when we ventilate, we are ventilating from a low pressure to a high pressure. And if you see the PV loop, it goes like that, right?
Yes.
Ventilation. Here in APRV, it drops down.
Yeah.
It goes like that.
Yeah.
Snap. Right. The pressure, this is how the PV loop goes, not like this.
Yeah.
It's just the opposite. So it's watch it is very different worldview.
So it's not like that. Like in APRV, patient should have spontaneous breath. Ideally,
right?
It usually ideally they should have, and their lungs are already inflated with air.
Yes.
In the high mode, in the upper high PEEP, they cannot take larger volume.
Large volumes, yes.
And only in the low pressure they can take they can take larger volume. CO2 also is better in when the PEEP is low. And
right.
But sometimes and also the time, because we have to see. Even we keep the P low time is very short, around like for one time constant, that is 0.8 seconds, or like maybe for ARDS time constant is lower than normal. So if it actually we cannot say like how much time constant will be this particular patient, but if at least 2 time constant if you give, that means almost almost like 30-40% lung airs are still there in the lung. Okay.
Yes,
So,
I agree. So the only thing is that the tidal volume generated on a high, as you rightly said, high level of CPAP is small, right?
yeah.
But the tidal volume that can be generated on the low level of CPAP is also small in this because it's a very brief release, right? A very brief.
Right. Correct.
So primarily the ventilation is happening because of what is called the release volume, not tidal volume.
Right.
Release from a higher pressure to a lower pressure.
Correct.
Titrating that is the most
Important.
PRV, that what is an adequate release volume without causing deregulation.
Yeah.
For that, you have to watch the
Like if we
flow time scaler.
If you keep a shorter low time for release, the ventilation won't be good. But if
Yes.
it's longer, then it will be de-recruitment. So we
That's
have
the
to balance
balance.
between de-recruitment and the hypercapnia.
Anybody any questions or something they can ask or raise?
Yeah, they can type the questions.
Because they'll get bored with us, chat.
Only.
Okay, I think we can move forward.
Yeah, any
Next
of you
question.
who thinks of a question, you can put it in the chat box, and yeah.
We will answer it.
I think now Sandeep will ask a question. So he will.
So we'll come to pharmacological therapy now. So first thing I would like to ask you is, since it is advances, so I have come up with one drug only, which is aviptadil, which is available in the market, which is marketed by an Indian company with lots of promises. I am yet to use it, but I am not sure. So if you have any experiences of using it, so theoretically, yes, they have given a lot of data, which is, and sometimes it is too good to be true. A lot of mortality benefits. You can use it anytime, or I mean, again, it works at any point of time in severe ARDS. So if you have any experiences about it.
Right. So aviptadil, the mechanisms of action are not very clear, but basically a lot of the endothelial leakiness that is there, that is vascular and endothelial leakiness of the alveolar and vascular endothelium is reduced. That is one of the causes of ARDS, and the new hyaline membrane formation is reduced, etc. So theoretically, they have a lot of things going for it, but unfortunately, most of the studies, real studies, this is the last study which came in NEJM, has shown, JAMA, right? The latest one is in JAMA, which showed no benefit in outcomes. So a pretty large trial, not industry sponsored, so showed no benefit of aviptadil. So at this present moment, I don't think we have any new drugs for ARDS. The principles of behind aviptadil is interesting, but unfortunately no new drugs which are in support, no study which really supports aviptadil. All the trials that they have shown, the industry shows us, are very small trials. They don't have mortality or ventilatory free days in the outcomes. There's a lot of statistical tweaking that they have done on that. So I don't think, I don't think aviptadil I would be using yet. The evidence is not strong enough. As far as any other drug you wanted to talk about, there's steroids or something?
Steroids.
Or any other drug which is
right now, none. So steroids, anything you would like to add, Saurabh, Sandeep?
Regarding?
Any other drug that you have in?
So there is nothing which is coming up as such, as far as I know. I mean,
people are they tried using atorvastatin, like simvastatins, but till now they are not found to be useful.
Absolutely.
So there is nothing which is promising, which is.
So I mean, see, what the problem is that with everything that we do in systemic illnesses like sepsis or an ARDS, is that the pathways are so multiple pathways of disease, and just blocking one thing is not going to change outcomes. That's also there. Other about steroids, the current role of steroids, the jury is still out on it. The DEXA ARDS showed that there was a benefit in outcome, but it was a composite outcome of ventilator-free days and mortality. Pure mortality outcome benefits plus minus. All the trials that Dr. Meduri does shows in ARDS benefit with steroids. All the trials that other groups have done generally don't tend to show. So there is almost like a split 50-50. In sepsis, all the trials that Anand and his group do shows a benefit in mortality with steroids, while all the other groups do not show that multi-center trial. So there are certain inherent biases which are already crept in, and I don't mean biases in terms of financial conflict of interest. It's an intellectual bias almost, I would say, that you are intellectually almost committed to the fact, and you have put your stakes on it, that saying that steroids would work. So that's there. But having said that, the role, Chirag has some questions. I'll come to that, Chirag. Okay. So the role of steroids in COVID-related ARDS, in the second week, it's the interesting part. In the second week, post-viremia, outcomes improve, right? Not in those on very high ventilatory support, but those on moderate support, etc. On oxygen, on ventilation, but very refractory hypoxemia probably didn't help. But in non-COVID ARDS, there actually, wherever it has been shown that there is some benefit, it has to be early, between 3 to 7 days, and outcomes are worse if you start steroids after 14 days. If you start steroids after 14 days. In H1N1 influenza, actually, there is no RCT, but observational trials, meta-analysis of trials have shown that harm with steroids. But that is possible maybe because of the fact that they were given during the phase of viremia. We do not know. Many a times we do not know the timing of that steroids. So probably one principle I would say to keep in mind would be that in a viral infection, a viral pneumonia, for the first week of the illness, I don't mean first week of ARDS, the first week of infection, probably a bad idea to start steroids, because you are going to prolong the viremia, and the viremia itself is going to continue producing an inflammatory response because of what it triggers in our immune system. Possibly a role in the second week onwards if the patient is in ARDS, right? With ARDS, patients with ARDS. In extrapulmonary ARDS, probably they have been shown to have a better outcome with steroids, but now CAP also, there seems to be a better outcome. CAP causing steroid, probably you will also, there is evidence to suggest that there is a possibility that there could be a better outcome. So as I said, the jury is out, and actually this is interesting, and I'm just is that in the research conclave of the Indian Society of Critical Care Medicine, we have decided to start a multi-center randomized controls trial of steroids in ARDS, because there is still equipoise, I think, and you have to give me your ideas, Saurabh, Sandeep, and anybody else, that should we do it or not, because I was asked to present it and I've made initial kind of a proposal, and it's just in the early stages. Do you think, and it doesn't cost too much money, do you think it is a good idea that there is a India ARDS trial, a multi-center trial, which the ISCCM network, research network is planning to do? So do you think it's a good idea to do it, or?
Yeah, definitely it's a good idea.
The same thing.
Even the CAP code trial, no, the recent trial, the use of steroid, the CAP code trial, that use of steroid in pneumonia, I think around 80% people, they have some form of ARDS. They are FIRO less than 300. They also showed through some light, like use of steroid in ARDS caused by pneumonia, I think.
Right.
And anything
ARDS trial also, yeah.
Any specific steroid? I think in the initial trials also, the benefit was with dexamethasone. Even before the Dexa ARDS trial, the proposition was because it is a longer acting steroid, and it works for, it mitigates the inflammation for a longer period of time. I don't remember exactly the trial name, but this is what I remember.
Meduri's trial, which showed benefit with 2 milligram per kg followed by 1 milligram per kg
Right.
one week.
Right,
That's
right,
methylprednisolone though.
right.
2 milligram per kg of methylpred. So yeah, I can't remember the DEXA trial. The DEXA trials have been successful in the COVID-related ARDS in the recovery platform.
You're talking about the DEXA ARDS trial?
Yeah, DEXA ARDS trial also shows benefit.
It was
There was-
methylprednisolone, I think, 60 mg.
There was a trial with dexamethasone earlier also.
Before DEXA ARDS.
in
Yeah, I can't
reading,
remember, yeah.
I don't remember that.
So
Okay.
there is a Chirag has
Controversy
been
continues.
sorry.
Okay.
Chirag has put up a question in the chat box
Yeah.
that how to elaborate on the setting of P low in APRV mode using the flow time scaler. Shall I take it?
Yes, sir.
Yes, sir.
Are we?
Short.
Yeah. Okay. So quickly.
Short period of time. Yes, sir. Quickly.
Yeah. So as Saurabh said, that if you look at time constants about in 2 time, usually rule of thumb 3 to 4 time constants, the lung completely empties out. The time constant becomes expiratory time constants become shorter in ARDS. The inspiratory time constant increases, right? So it's a brief time that it is takes much less time to empty out the lung, and that's the problem. You know, the alveoli tend to shut down. So the principle is, if you see the expiratory flow time scalar, look at the angle of the graph. If the expiratory or the release time is long, the expiratory flow goes close to the baseline before the next rise in pressure to the next CPAP, next high CPAP level, then you are de-recruiting the lung. If your angle is too sharp, that means you have a too brief a one and your angle is too sharp, then also you are over distending the lung and you're not allowing enough release. So the angle, so if this is the x-axis and this is your expiratory flow initially, and this is after the initial flow, it has this angle. So the angle between this part of the graph and this, when it touches the, if you can see my hands, it touches the baseline. If that angle is about 45 degrees, I mean, it's not exact, 40 to anywhere between 40 to 50 degrees, then that means you have caused enough release without causing de-recruitment, right? So that is how you have to, that's how the expiratory flow time scalar helps you in APRV.
Okay.
Right.
Sir, the next question is on neuromuscular blocker in ARDS. We know the benefits of should I ask the question? Okay.
I know. So you want to?
So we know, let's just explain the.
Yeah, sure.
So we know they have multiple benefits. They decrease the strong inspiratory drive, and that can cause villi. They may improve oxygenation. They also prevent active aspiration. They may decrease inflammatory cytokines, and they can also help reducing breathtaking. The ARDS net curation systemic trial, that is ECORESIS trial. After this trial, we all started using neuromuscular blockers for 48 hours. Then the next trial came, that is ROSE trial, and ROSE trial was larger trial. It has around more than 1,000 patients. And this trial, they didn't show any benefit of using routine use of neuromuscular blocker in person of ARDS. Now that ESM guidelines says that they recommend against routine use of neuromuscular blocker, not that use of neuromuscular blocker. They recommend against routine use of. So now our job is more difficult, because earlier we used to use ATRA in all patients. Now we have to be selective where to use and where not to use. So I would like to ask you, sir, how to choose which patient we should give neuromuscular blocker and which we should not give.
Yeah. So I think sometimes when the guidelines are not clear, we use our understanding of pathophysiology a little better and think through things that we are supposed to do rather than go by just guidelines. guidelines are always good, as I keep saying, about improving the lowest common denominator of care. But guidelines also tend to reduce our, if we follow guidelines like, God's word, then it reduces our ability to intellectualize, use our brains and our clinical understanding. So sometimes I feel very happy when there are a little confusion in the guidelines, that then we'll use our brains a little more. So why, as you have put it in the slides beautifully, that the reason for probably the success, that the reason that you use a neuromuscular blockade is to reduce what is now termed PCLI, which is exaggerated spontaneous breathing leading to patient self-inflicted lung injury. I don't like the term PCLI because it almost blames the patient for his own poor health or poor condition. I don't like using terminology like that, but not having a better term right now, I would say just say silly probably. So to prevent silly exaggerated breathing, when you have exaggerated negative pressure breathing on a positive pressure ventilation, your transpulmonary pressures increase, and that is what you're trying to stop. But neuromuscular blockade has its own consequences, diaphragmatic paresis, weakness, neuromuscular weakness, etc. So before this guideline came, actually the European Society came up with a very interesting, what is called what they call an ICG, rapid, it's a, what's it called, a rapid guideline for which you could use to titrate neuromuscular blockade. This came in 2021, actually, 20. So it was, I found it very useful. So which is now part of their, I think part of the guideline also, if I can't remember now, I think they have an algorithm there. So how I use it, when I intubate, obviously, when we intubate a patient with ARDS, we use a relaxant, etc. Give an initial relaxant, see the mechanics, and use very deep sedation initially. I mean, not deep, very deep, but deep sedation, and see how it goes. If the patient is dysynchronous, has exaggerated spontaneous breathing on sedation, deepen the sedation and give a shot of neuromuscular blockade. If by that time we have been able to improve the mechanics, respiratory mechanics, by whatever it takes, titrating the PEEP right, so his oxygen demand, his end expiratory lung volume, his FRC, etc., has improved, then his drive reduces sometimes, right? Sometimes because of the inflammatory response, it may not reduce. If that happens, well and good, then we do not use neuromuscular blockade. Or we use it intermittently whenever we feel that the patient now, sometimes morning time when we are turning the patient, doing the nursing care, they require a little more sedation, probably knock him out or her out at that moment. Only those where we are, in spite of deep sedation and intermittent boluses, we are finding it difficult to control their exaggerated spontaneous breathing and their respiratory drive, do we use an infusion. And that too, there is no fixed 48 hours. We do for 12 to 16 hours, particularly the overnight phase when we are less staffing, etc. The first 24-hour phase, particularly the overnight phase, and then see again in the morning, stop it and see how the patient is doing, evaluate, titrate sedation. When the larger team is there, a little more doctors with a little more experience who can evaluate what could be done. Then if necessary, we go back to muscle relaxant continuous infusion. But most of the time now, it is very, very rare that I use continuous infusions of neuromuscular blockade. Intermittent boluses with deep sedation, it reduces the RAS score significantly sometimes. And because we are not trying to wake them up for, weaning trials, spontaneous breathing trials initially. So you can actually deepen the sedation. The misconception that is there, that you have to wake up the patient every day, it's a misconception. You wake them up only when you are thinking that they are ready to in severe ARDS, you don't have to wake them up necessarily. Right. So you have to, sometimes this habit of stopping sedation in the morning to wake up as a protocol is dangerous. It should only be done in patients who have improved and you believe that there is a chance of weaning, right? So combining these two factors, I think, and having a RAS score or whatever score you use to titrate the sedation is very useful. It gives a nurse and a younger resident who's new to know what to titrate the sedation at, and then if it doesn't work, then only you give a relaxant. Our use of muscle relaxants has reduced significantly actually after that.
Thank you, sir.
Good answer.
Yeah. So next, Dr.
question.
Sandeep can ask a question.
Huh.
I think.
Anything you'd like to add, Sandeep?
Yes, sir. I think you have rightly said that there is a problem with this, what we say, evidence-based medicines. So I've been following all these trials since, let's say, last 15 years, 15, 17 years. Evidences change. I mean, they keep on changing, and I feel that you keep on coming back to your previous ones. So there was something that we used to do. I still remember we tend not to prone patients initially when I was there.
Yes.
But then one trial came and we started proning everything, and now everyone was being saved. So mortality was getting better, but which was not getting better earlier. I mean, similar things with these NMBs. So I still remember when this accuracy trial came, there was a strong discussion with, I think, Dr. Deepa Google, that this NEJM trial has come and it shows that it is going to get benefits. And there was a heated sort of discussion that how it is going to work. There is no reason for it to work. So there was these kind of things. And later on, it changes. As you rightly said, that it is always better to use your brains, and guidelines probably should be taken up as rough guidelines. I mean,
Yes.
they are not God's words.
Also, you see the understanding of pathophysiology.
Yes.
Constantly working to improve our understanding of pathophysiology at the larger scientific level, but at our personal level. And that requires constant reading, trying to understand. I keep trying and understand, and all of us, not me, just all of us try to keep improving our understanding, right? That is most important. Just because jumping to things because a new guideline is within the guideline, asking the question, why has it come? Why do you think it would work? Even if it is in the guideline. Right. So that is important. That science, we have to realize science is about the best understanding at that point of time, does not mean that we stop asking questions. It is not a belief system. It's not a belief system. We have to, even without being unscientific, saying that everything is wrong, all guidelines are bad, all guidelines cannot become belief systems on one hand. Second is that science works by changing, shifting, moving as our understanding improves. And always that slight skepticism or hesitancy to use something which has come immediately, always ask the question, why? Really, I mean, that is what we tend not to do. Our education system somehow does not make us do that as regularly as we should. We are doing it more and more, I think. But somehow that thing, now that, I have lots of journalist friends and good journalists. I don't mean, who's always, and I'm amazed at their ability. Something happens. This is the supposed common sense that this is the reason why it happens. They will say, why? Let us find why. That is a very important factor in science. They usually come from social science backgrounds, but they have a much more scientific rationale to these things than we have. We tend to accept much more that we do not ask enough questions. I'm not saying be a complete, non-believer in, science, but constantly asking questions. That is more scientific than completely believing every new thing that comes.
Correct.
Sorry.
Now coming to the ventilation part again.
Right.
So as of now, low tidal volume of 4 to 6 ml per kg of predicted body weight and limiting plateau pressures of less than 30 centimeters of water. These are two very well established, which is called protective lung ventilation, are well established. But is it okay? Is it okay for all the patients? Can we individualize? What should be the criteria? How we can individualize specifically in morbidly obese patients where, because of very poor chest compliance, we cannot always manage plateau pressures of less than 30 centimeters of water. So what would be the right way of, say, ventilating a patient who is really, really obese, comes with ARDS, or some other sort of reason because of his poor chest compliance? Can transpulmonary pressure monitoring help us? And what may be the right way to do it?
Well, transpulmonary pressure monitoring, difficult. not available easily. Having said that, there can be a role in small subset of patients. Every patient, we probably don't need to put a transpulmonary catheter. One. Second is that if we don't have a transpulmonary catheter by itself doesn't restrict us from doing a good job. So two things in that transpulmonary catheter, again, it is when the placement of it, we place it usually to measure the pressure at the left lung lower lobe, right? That's about the side, the lower third of the esophagus, etc. Now, how do you titrate the, on one hand, the end expiratory pressure should not be negative when you titrate your PEEP with that. And on the plateau pressure side, you have to, basically it helps us differentiate between the chest compliance versus the lung compliance, so differentiating that, right? So the pleural pressure. So, but there are many caveats. It is, can we extrapolate the pressure that we measure at just one area of the lung to the whole lung in a badly diffuse disease process? Yes and no. To a certain extent, yes. It gives us a sense, gives us an idea, but it is not a perfect measure. It can only indicate to us, because it is well known that something called solid-like behavior and fluid-like behavior of a lung, right? Normal good lung behaves in what is called a fluid-like behavior when a pressure that you measure at one part of the lung gets transmitted, the pleural pressure, etc., to the rest of the lung almost simultaneously at the same level. But in a solid-like behavior in a badly damaged lung, it behaves very differently. Different areas of the lung, different regions will have completely different pressure swings with changes in pleural pressure and transpulmonary pressure. So the swings are completely different. So can we completely believe in that? And it's difficult to do that. In obese patients, it helps us to differentiate that the plateau pressure that you are measuring is not the plateau pressure, that is not because of the lung compliance, it is also the chest compliance. It may be of benefit. So that is a potential use, but with its difficulties. The other is probably another way to look at it. If you don't have that, intra-abdominal pressure, measure the intra-abdominal pressure and look at the element of transmission of intra-abdominal pressure to the thoracic cage. And there has been, studies, obviously it's a range of pressures which gets transmitted. Anywhere between the transmission of the intra-abdominal pressure to the intrathoracic pressure can be anywhere between 20% of the pressure to 60% of the pressure, intra-abdominal pressure, if you have an abdominal compartment syndrome or in a morbidly obese patient, can get transmitted to the thoracic cage, right? So you have to bring in that element when you calculate what the plateau pressure is. There are certain simple arithmetic calculations which are there, which could be useful, that if you have an intra-abdominal pressure which is higher than 10 millimeter of Hg, then probably how much it is higher by about 70% of 50 to 60% of that you can add on your plateau pressure. You can Google it. It usually adds to, about, suppose your intra-abdominal pressure is 20 and actually normally your intra-abdominal pressure is 10. So the 10 more. So because it's millimeter Hg and your transpulmonary pressure you are measuring in centimeters water, so it is about 7 you add to the 30 centimeters of water. For simplification, right? But acceptable pressures will be a little higher. As all of you know, the trials haven't shown much mortality benefit with transpulmonary pressure or what is called pleural pressure measurement and transpulmonary pressure measurement. But the titration of PEEP to not allow it to go into the negative, and titration of the plateau pressure has been better. Oxygenation has been better, but outcome has not improved with that. But it is a modality which will become useful in a small subset of patients when we learn how to use it a little better and the caveats associated with it.
Sir, actually, transpulmonary pressure can be also used, with help of esophageal probing. And
sorry, what is that?
Esophageal probe.
Esophageal
probe. Obviously, esophageal probe only will be. Yeah.
But again, as you said, when the lung is not good, it does not behave like a fluid. then that esophageal probe may not be a good reflection of intrapulmonary pressure. So again,
Right.
like, when we give high sedation or use paralysis, as you do in the ARDS patient, what the intrapleural pressure is almost like zero, right, sir? So in that case, how it is beneficial? How the measurement is beneficial in patient with ARDS? It is transpulmonary pressure is like airway pressure minus intrapleural pressure. And when there is no intrapleural activity, patient is not breathing, then it is almost zero.
Yeah.
Like that. So
Yeah. So, but what happens is the pleural pressure, because of the thoracic, either the
Just
compliance of the thoracic cage, right? And so you could, the airway pressures and the pleural pressure, the difference, if because of the thoracic cage compliance difference, will
Right.
give you that what is the airway pressure and what is the pleural pressure, the difference in that, right, would give you the actual pressure that you are reaching at the
Correct.
lung level to a certain extent, but
Correct.
completely knocked out
Yeah.
patient with, yeah, that would be the difficult one, but that is the pressure range when it drops from a high pressure to a low pressure.
Yeah.
That is where you would like.
So it is I think it is more helpful when patient is breathing spontaneously.
Yes, there is.
That will correct. Will,
Absolutely.
yeah. For
Absolutely.
patient who is paralyzed, then the descending pressure is the airway pressure. And when patient is also spontaneous breathing, plus we are also supporting the breath, then the transpulmonary pressure is more accurate.
Is more benefit. Absolutely, I agree. Absolutely.
Regarding the volumes, 4, 6, and he asked the question like whether we should keep the pressure less than 30 centimeter or water. What I
Sorry,
feel,
come again?
what I feel that ARDS is not the problem with the lung. It also affects the heart. And I did a meta-analysis, and I found that 22% of patients who are ventilated with lung protective ventilation, that means the platelet is less than 30, 22% of patient has acute core pulmonary.
Has what? Sorry?
more than that.
Acute core pulmonary. Now,
Yes.
I did a meta-analysis.
Meta-analysis 22%, right?
Yeah, I found it is 22%.
Oh, very nice. I didn't know that's meta-analysis. It is exactly what the two French groups did. Exact percentage. Very interesting.
Yeah, it has long time. I did
Exactly
it
22%. Obviously, it must have come from the studies because you meta-analyzed them.
Yeah. So they
Yeah.
So now people, they are trying to reduce this volume also. They actually, the lower platelet is better. This is not that 30 is safe.
Yes.
Lower is better.
Yes.
So
The lower
now,
you can achieve. Yes.
yeah.
Lower is better.
Now people, they are trying to go try with ultra low tidal volume. That is 3 ml,
Right.
3 ml per kg volume, along with the ACOR.
Yes.
Yeah, but so far they are not found to be like beneficial. Even the latest, there are numbers of study trials using ACORs like Supernova,
Yes, Supernova.
REST trial, etc. This REST trial is the latest trial. I think it was published in 2021, something like that. And they found didn't like any benefit of ACOR and low tidal volume.
Right.
So, what do you think? Like, what's the problem?
Yes. So I personally think, I don't know if it's going to, my belief is that in patients where we are requiring, I mean, I won't say high, but requiring 30 or that amount of plateau pressure to maintain ventilation and oxygenation, fairly severe disease, I think a significant, I mean, I don't know what term to use, but supraprotective ventilation, if we call it, 3 to 4 ml, maintaining a plateau pressure lower, driving pressure lower, that's just a sign of compliance. And reducing the energy use, right?
Yeah.
Reducing the energy used to ventilate the patient and oxygenate the patient. So I believe that all natural systems have a certain entropy, certain level of energy requirement. When we exceed it significantly, it will always cause damage, and natural systems include our environment. And we see that, right? Our excessive use of energy has caused what damage we have done to the climate, right?
Correct.
I believe that. So the same applies for the lungs. But the point is, if we don't use energy here in ventilating or, expanding the lung and gas exchange, then we are doing it somewhere else by either an ECMO or an ECOR, right?
Correct.
ECOR, I believe that CO2 removal with ECOR, with lung protective ventilation, eventually as our equipment improves, will be probably the answer. Physiologically, it makes sense to me. Why doesn't ECMO make sense to me as much? I mean, I'm not saying that there have not been survival, doesn't happen. ECMO, you see the way the machine works, the pump works, the ECOR can be pumpless, right? It does the physiological flow of the
correct.
body, right?
Yeah.
When we use a pump through an oxygenator, you are releasing cytokines.
Correct.
Just doing that, you
Yes.
are, thrombogenicity, etc. is one. One is you are releasing cytokines. You are causing an inflammatory response by the ECMO itself, right? And energy. So possibility that would benefit using it long term, I find it a little difficult to take. I may be wrong. I mean, that is my understanding. But absolutely agree with you. That sort of that. My feeling is with better ECOR equipment, that will probably be the way to go. I was a little disappointed with the Supernova and the REST trial, but it's okay. I mean, this is what science is about. But I would think that physiologically it makes sense. What do you think, Sandeep?
It definitely makes sense. In fact, I don't know why the trials have failed, but again, this goes with the concept. I mean, the physiological
Yes.
concept. It goes with the concept and should work. The only problem with we are solving the only problem with ultra low tidal volumes and with the limitation of pressures.
Yes, and
But that
also I think
should work.
yeah. Also, I think there's so many complexities in a severe illness, right?
Yes,
So
sir. Okay.
I
So,
think we take up last question. I think it is.
this is the last question. Should I take or you ask or I will ask?
No, you ask. Go ahead.
Sir,
I think we have talked about phenotype.
yeah.
You want to talk about phenotype?
Yeah. So, sir, what we do, like usually when we get a patient with sepsis or patient with ARDS, we take all the patient like a homogeneous patient, and we give similar treatment to all patients. But some patient they respond and some patient they don't respond. That means that the population is not homogeneous, and there's some heterogeneity in the population. So we need to, I think we need to give different therapy to the different patient. That is where we what you said is a precision medicine. Now the phenotype is like we know genotype, that is genetic allele. Phenotype is like what is a combination of genes and the environmental factors. Then there is subgroups. Subgroups is like nothing. Like suppose we do subgrouping arbitrary. Suppose procal high, procal low, TLC high, TLC low. Subphenotype is a group that are distinct from the other group. For example, the patient with hyperinflammation and patient is hypoinflammation. There are multiple tests. There are like battery of tests to distinguish this patient. And the endotype is the mechanism. What is causing this subphenotype? So now we have identified different type of subphenotype in patient with ARDS, like hyperinflammation, hypoinflammation, according to the X-ray finding, whether they are diffuse or whether this is focal or whether they are recruitable or non-recruitable. Till now, we have found that different phenotypes have different prognosis. But when we try to treat them differently, till now, we have not found any benefit. But sir, lack of evidence of crime is not the evidence of absence of crime. Just till now we have not found any evidence. So now, how do you think? How should we divide our patient, and how should we precisely treat patient with ARDS? How should we use phenotyping in our clinical practice?
Right, a very good question, and also when this I'd been waiting for a long time for Caroline Calfee to be a part of this guideline. And if you see, the second author of this guideline is Caroline Calfee.
Okay.
She and her group in California has done some of the most amount of work on ARDS phenotypes. You'll see the second author is Caroline Calfee, and I was very excited. I knew that phenotypes and subphenotypes are here to stay when she became the second author of this, and equal to the first author anyway. So that apart. So Caroline Calfee's work I've been following for about 9-10 years, and when it was not that popular, and it's very interesting. And so how do we try? And you see, I think we do it ourselves to a certain extent, and sometimes we don't do it. When we use an ARDS net table to titrate our PEEP, we are doing injustice to the patient, because you have to titrate PEEP not on the FiO2, but on the patient's compliance and change in compliance when you change the PEEP. I do not believe that high PEEP versus low PEEP, those are poorly planned trials.
Yes.
What was a very good planned trial in some way was the ART trial, where they titrated the PEEP, but they make the mistake of using very high recruitment pressures and very prolonged recruitments that has its own consequences, and we can come to that later. So I think we are already doing some of it by titrating the PEEP that we give. And again, Caroline Calfee's latent class analysis showed that the two subgroups that she divided into, the phenotype 1 and 2, behave differently. The phenotype 2, which had more shock, actually did better with higher PEEP. The mortality was less with higher PEEP. But on the bedside in a patient, you will not know that this is, may or may not know this is phenotype 1 or 2 unless you send certain markers. Okay. But having said that, you can titrate the PEEP rather than fixed PEEP for FiO2. One is that. Second is fluid. Negative fluid, positive fluid, less fluid, more fluid. Again, they analyzed the latent class analysis of the FACT trial. They exactly found that the phenotype 2, which is the inflammatory phenotype, right, which had more shock, did better with less fluids.
Yes.
Though they were in shock.
Yes.
So they had a more leaky endothelium.
Yeah.
Right. Inflammatory response, more leaky endothelium, the fluid leaked out. Right. So in that setting, when you are seeing that you are giving fluids, so titrate fluid boluses and see the outcomes of that fluid boluses rather than having a set amount. And fluid bolus, cardiac output monitoring, or just look at the pulse pressure to a certain extent, you will give an idea. Look at the oxygenation. If it worsens with fluid bolus, do not give. And your vasopressor requirement is there in ARDS, add a little more vasopressor in that setting rather than more fluid. So these are the things you titrate. Okay, having said that, does the phenotype maintain consistency throughout the disease process?
Yes. Also not.
That's what happened in COVID. That's why the L and the H type got debunked.
Yeah.
Right? It is similar. The L and H type is exactly similar. The H type is exactly similar to the phenotype 2 of Caroline Calfee's group. And L type is almost exactly similar to the phenotype 1 of Caroline Calfee's group. But why did it not prove itself in the long run is that the terminology had to be stopped, is that even with the same patient starting off in a certain phase, it may be a phenotype which shifts. Can we name it a phenotype? I do not know yet, because if it's shifting, then can we fix it in a phenotype? Right? Having said that, clinically at the bedside, you have to see how the response is of this patient to what you are doing. Yes. What you are doing doesn't seem to work. Step back and think that what will work for this patient. Right? So this just tells us that, yes, we are in the early phase of phenotype differentiation. Correct. We got a sense, and I think it is even before Caroline Calfee told us or the H and L type came to us, most of us who have worked for a few years in ARDS had a sense that, some patients don't do well with fluids and some patients with PEEP, right? So to titrate it was more important. So size does not fit all. Yeah. There will be phenotypes. How do we differentiate the phenotypes is going to take time. At this present moment, we have some answers which tells us early in the phase which phenotype they fall. When the phase of fibroproliferative phase goes into the more fibrotic phase, their patterns of behavior may change. Some patients will not go to the fibrotic phase. They will. So the phenotype 2 not going into the fibrotic phase will behave later in the ARDS differently from a phenotype 2, inflammatory phenotype, going into a fibrotic phase after 2 weeks or 3 weeks. So you have the whole pathway you have to see in that. So if you want simple answers, there are no simple answers, and that is the excitement of medicine, I think. Yeah. Or AI can take over from us. AI at this present moment in my lifetime probably is not going to take away. They will be very helpful. AI will be very, very helpful, particularly to tease out these phenotypes actually. Big data analysis. Correct. Help us tease out these But at the bedside in that individual patient, if we do not put our brains, we will be replaced by AI. In my lifetime, it won't happen. Saurabh, Sandeep, you are younger and the people listening are younger. Maybe in your lifetime. I'm hoping not in my lifetime.
Even we're hoping the same.
It's just 10 years maximum.
But it has already come. We cannot stop.
No, AI will come.
Inevitable.
AI will come.
Yeah.
Point is, AI is important. AI is useful. But all technologies, understand this. It's not just AI.
And
all technologies have pros and cons, benefits and
Sir,
right. And AI will be useful is how we use it.
Yes, correct.
Completely replace us will depend on two things, how it develops, and I can't predict to the future of 25. 10 years from now, it will be very beneficial. Radio diagnosis, it will replace a lot of radiologists, anything. But in clinical medicine, it will take longer. Will it or not do it? I do not know. It will be very helpful for us, but I don't think in the next 10, 15 years is going to replace us.
And sir, I hope it is not AI or me. I think it is AI and me.
Yes, AI and us has to work.
Yes. We should know
realize that all technologies have a problem.
Yeah.
They have the potential of harm too.
Yeah.
Does many things, and it's not to do with AI. It has always historically even had steam engines and trains coming in, right?
Yeah.
Trains, improved transport, but it damaged environment. Lots of things happened. Constant balance. It is how society controls it, plays it, where we take it from. It's developed by human beings. It has to be, the checks and balances has to be by the human brain.
Yes.
Leave it completely for AI to control itself. That is the big fear for me.
Okay, I think.
Yeah. I think this is the end of this session.
I think there are
any audience can ask any question.
I think there can be a lot of questions, but I would again insist here that the platform is designed in a way that we will announce you all the topics, and I would again request, because this is the first meeting here, please put up all your questions before the meeting. Here we have tried that we'll take up all the questions that you have asked to the respective guests, and we'll try and answer those, because otherwise it is going to be very, very long and endless. Right. But yes, we can take up one or two questions. There are
one
not
question that
too many questions are there.
Preeti Arya has put. Good question. Patient who has already exposed to high plateau pressures, more than 30 centimeters of water for more than 7 days. Is there any benefit of ECMO? Well, usually that late, but selection of patients for ECMO is one of the most difficult questions.
Yes.
I mean, there are many, the ELSO guidelines, probably Saurabh and Sandeep will tell us better than I can. But one of the principles that I found very useful that the French used to use, I don't know if they still use it, is that, making this patterns of where to go for ECMO. One is what the Eolia trial did, that if you severe hypoxemia, PF ratio less than 50 or 80, some number of hours, that number of hours can change, a little bit, 6 to 8 hours or not. But if you have high plateau pressure, then you have not prone, or you have proned for 3-4 cycles of proning and that is not helping, then it is probably an attempt should be made to go for ECMO at this present moment of evidence. 7 days means if the PF, it's not just the plateau pressure, the PF ratio. Why would you allow the plateau pressure to rise so much? The reason is hypoxemia or hypercarbia. That also needs to be considered. That you are using high plateau pressures because you are not able to maintain oxygenation. That's why you are continuing to use high plateau pressures, or you are you're not adequately hypoventilating the patient to maintain the plateau pressures. So if it is CO2 and your oxygenation is okay and you are allowing the allowing the plateau pressures to rise to deliver certain amount of minute ventilation for CO2, probably an ECOR could help. And ECMO in the subset where both oxygenation and hypercarbia are involved. Anything else you would like to add? You guys know better than me about.
So there was one statement that I read maybe few years down the line was that if you need to breach your ARDS-net protocol, specifically if you need to breach your 30 centimeters of water protocol of plateau pressure, probably you should start thinking about ECMO.
ECMO. Yeah, that's a good way to put it. Yeah.
So I think this is okay. I will leave the students specifically with one last question, as I am fond of putting up questions, not the answers only. So I'll leave you with some thought at the end. Saurabh, you can conclude.
Okay. So do you want to ask any question or what? So Sandeep?
I think
It's okay,
it is
no?
okay.
Yeah.
I think we have discussed this also.
Thank you, Dr. Sandeep, for this nice initiative, and Sumit sir for giving us time again. I know you're very busy in both academic and administrative job. I think we'll meet you again on 4th August. We have a conference. We'll meet there.
We would definitely keep on giving you trouble, sir, and it will be
No trouble at all.
It will be a benefit to us and to all the students. Like we have learned from you, and they will also be able to learn from you.
And thank you, audience, for joining. And as sir said, keep asking questions. I wrote on my back. Keep asking questions to yourself, to Sumit sir, or to anyone you get.
To yourself.
Most of will ask yourself.
And thank you for giving me the opportunity. And as no trouble, it's just sometimes time management. I'm not very great with time management. That's why. But it always getting questions, thinking through. I mean, like all of us, we don't have all the answers. We are trying to work through the answers as we answer, I think, isn't it? So that also keeps our brain active. There's no better learning than, discussion and thank you. Thank you so much.
So the last thing that I would leave the students with that I said. So we had discussed about plateau pressures of 30. One good question which I do ask, where from this figure of 30 centimeters of water, this magical figure of 30, why 30 only? From where has it come? Why 30? Why do we think of ECMO beyond 30? Why 30? So that is one question that you can think of, that we can discuss later on.
Next time.
Yes.
You give the answer in next session, right?
Or you can put it in the Facebook also. You can
Thank you, everyone. Thank you, sir. Good night.
Good night. Good evening.
Thank you,
everyone. Thank you, sir. Bye, Saurabh.